very much. Okay, the third speaker is Sherene Loi, the Australia. She will talk about targeting the immune pathway. Please.
Good afternoon, everyone. I'd like to thank the organising committee for the invitation to speak today, and I'm going to be talking about targeting immunity in breast cancer and the recent updates in the last 2 years. These are my disclosures. So why target immunity in breast cancer? So pathologists have long observed the presence of immune infiltrates in breast cancers. In some patients, this is a very dense infiltration, as we see here, and some patients have hardly any infiltration. So this begs the question that many researchers, including my lab, have asked for at least the last 100 years of why some breast cancers have this immune infiltrate and what is the clinical relevance. And it really wasn't until the advent of genome-wide technologies that we began to realise that breast cancer was not just one disease, but at least 3 different subtypes. And the immune signal in breast cancer became clearer in that it seemed to be most prognostic in the triple-negative and HER2-positive breast cancer subtypes. So my colleagues, Dr. Denkard and Salgado, have developed a method, and this is a method of evaluating quantity of immune infiltration in breast cancers, and we developed this method to be pragmatic. So it involves a pathologist, though this in the future might be a computer, a light microscope, and simply H&E stain slides, which are available from every breast cancer specimen. It evaluates the percentage infiltration in the breast cancer stroma, and we've subsequently developed a training tool which is available for everyone to learn how to do this online. I'll note here that breast cancers are not as highly infiltrated as other solid tumour types such as melanoma and lung cancer, which are thought to be the more immunogenic tumour types, but this method was evolved so we could access a large number of breast cancer specimens to try and understand the true prognostic value of this biomarker in the setting of breast cancer. So subsequently, we've recently performed a pooled analysis, which was mentioned earlier today, of over 2,000 patients from 9 studies, 8 of which were randomised clinical trials, with clinical outcome and TIL evaluation using the method that I've described. What we observed was that high TIL quantity was significantly associated with younger age, smaller tumour size, and less nodal involvement. So this suggests that anti-tumour immunity is actually controlling tumour burden to some extent in some patients. TIL quantity was strongly significant in the univariate and multivariate analysis, so that for every 10% increment in TIL, there was a 17% decrease in the risk of relapse or death. What we then tried to understand was the exact prognostic value of the TIL biomarker when integrated with our usual clinical pathological factors, including age, tumour size, nodal status, and grade. So we did this by using a likelihood ratio chi-squared statistic. So this is shown on the y-axis, and this represents a higher chi-squared value indicates more prognostic information is derived from the variables. Clinical pathological factors is there on your left, and that gives a significant value. That means that provides a significant amount of prognostic information for that patient. If you look at what the stromal TIL variable provides, you can see that's almost 1/3 of the information of the clinical pathological variables combined. So to put this into context, this amount is similar, if not more, to what a genomic assay provides in hormone-positive breast cancers. If you combine the TIL biomarker with clinical pathological factors, you can see that this prognostic information is significantly increased. And on the right there, you can see that this just simply deducts one from another, that clinical pathological and TIL provide independent information. So this information or independent information is highlighted here, where you can see the prognostic information by nodal status. So node-negative patients have an excellent distant disease-free survival if they have high TIL. Their 3-year estimated survival is 97% and overall survival 99%, but even the node 1 to 3 patients still have very impressive distant disease and overall survival. And if we look here at the patients who have 4 or more positive nodes, you can see that their survival is massively increased through the presence of TIL. So even though these patients are doing badly, this begs the question, if we can modulate immunity to increase their TIL count, that we can further improve their survival. So this algorithm is actually available on a website, so this allows clinicians to try and understand more accurately estimates of prognosis in patients with early stage triple-negative breast cancer, and this was supported by the BCRF. And as was mentioned yesterday, even though the TIL biomarker doesn't directly influence your treatment per se, because all the studies were performed in the context of chemotherapy, this does allow patients to have a more accurate understanding of their prognosis and potentially may allow us to design clinical trials in the future to target the higher risk patients. And as a result, this biomarker will be included in the WHO classification of breast tumours this year. So what is the immune infiltrate in breast cancer comprised of? So quantity of immune infiltrate, simply measured on H&E stain slides on your y-axis, is strongly correlated to more T cells. And you can see this here looking at the x-axis with CD8 RNA expression. Higher TIL equates more CD8 gene expression. We've also looked at this using flow cytometry, and again, higher TIL on H&E stain slides equates higher CD3 positive T cells on flow cytometry. So this is most likely why this biomarker is so robust, that quantity equates high number of T cells. When you dig down into the actual types of T cells that are there, you can see that the higher TIL, again on the y-axis, equates higher CD8 positive T cells. And we all know that CD8 positive T cells are those that are most important in the anti-tumour response. Again, digging down into what type of T cells are present in the breast cancer, and these pie charts simply represent the type of T cells for CD4s and CD8s, and to cut a long story short, the majority of the blue represents that these T cells are memory T cells. So these T cells have seen antigen. And what are the checkpoints that are present on the breast cancer immune infiltrate? So this is one way we've looked at it using mRNA, and you can see on the very top row there that high level of TIL correlates to high levels of PD-1, PD-L1 and CTLA-4 expression. So the more TIL you have, the more expression of these markers is also observed. Looking at this at the protein level, we observe similar things. You can see that in all patients, PD-1 is the dominant checkpoint. It's present on all 4s and 8s, and this is the same across all subtypes, TNBC, HER2, and luminal. If you look below CTLA-4, CTLA-4 is highly expressed on the CD4s as opposed to CD8s. And this, again, is consistent across all breast cancer subtypes. We've also looked at a number of other T-cell checkpoints, but it's very clear that the dominant checkpoints in breast cancer are PD-1 and CTLA-4. We've also looked at Tregs, and even though these are present in moderate amounts, these certainly are not as dominant as the PD-1 positive T cells or the CTLA-4, CD4 positive T cells. But just to highlight news updates in the last 2 years is that we're beginning to understand there's even more heterogeneity in the T-cell infiltrate. So this is some data that we've done looking at single-cell RNA sequencing of the T-cell infiltrate from 2 high-TIL breast cancers. So this is over 6,000 single T-cells. And you can see that these are not just CD4s and CD8s. There's at least 5 different clusters of CD4 T-cells. These are different based on gene expression. And again, 4 different distinct clusters of CD8 positive T-cells. So there's heterogeneity in this T-cell population, and we tried to understand how relevant this heterogeneity was. And in particular, we were interested in this top red group. This was a CD8 positive T-cell positive group, and we were interested because these T cells had high expression of a marker called integrin, or CD103. So this marker is associated with tissue residency. So these T cells have acquired the phenotype to stay resident in the tissue, to not recirculate, to provide a barrier or an immune response against, described mainly in infection models, but potentially applicable to tumours, to tumour antigen. So the most interesting thing about this particular T cell subset, because not all T cells expressed the checkpoint, so it was only this specific CD8 positive T cell cluster that expressed PD-1 and other checkpoints such as LAG3, so it's very plausible that when you give an agent such as a checkpoint inhibitor, that this agent is only affecting these specific T cells. And to highlight the heterogeneity present in the CD8 population, we extracted a signature, an RNA signature, comparing the CD8 TRMs compared to the non-TRMs, and you can see that it does, the heterogeneity matters. And the top two curves there on that Kaplan-Meier chart shows that if you have high TRM populations, it doesn't matter whether you have a significant amount of CD8 cells or not, it seems that the TRM population matters in determining prognosis in triple-negative breast cancer. So just coming to clinical data of what we've learned in the last 2 years, in the clinical data that's emerged looking at checkpoint inhibition, specifically PD-1, PD-L1 inhibition in breast cancer. So this is updates in triple-negative breast cancer, and what we've learned is that metastatic triple-negative breast cancer that has previously been treated, second or beyond, does not derive much benefit from, in this case, pembrolizumab monotherapy. And you can see here that the response rates observed were very low, and this was independent of PD-L1 status. So there's many reasons, many plausible hypotheses about why this may be the case. In this setting, we know that tumour is very aggressive, patients have very short PFS, so it's possible that the aggressiveness of the tumour is too fast for the immune system to keep up. There's also potential factors such as tumour burden, which results in T-cell exclusion, immune ignorance, so the tumours have lost antigen or lost HLA, or the presence of other immune checkpoints or regulators, for example, myeloid cells or macrophages. In contrast, cohort B, which was previously untreated PD-L1 positive, showed a much higher response rate here of 21%, suggesting that prior treatment makes a difference in the advanced setting, and there needs to be some enrichment of anti-tumour immunity in these breast cancer patients, which makes sense, of course, because these inhibitors are targeting T cells, so you need to have some T cell present in order to derive a response. So how can we quantify anti-tumour immunity that is present in the tumour? So you can do that using PD-L1, I guess. And we've also looked at this using STIL, as I previously described. And you could probably do this using CD8 or CD3 or a number of other immune markers, because they're all potentially correlated in that they read out a T-cell response, and they all suggest the presence of some sort of pre-existing anti-tumour, specifically T-cell immunity. And I show here that in Keynote-86, TIL level, as quantified using our method on H&E stained slides, was strongly correlated with PD-L1 expression using the Merck assay. And in this particular study, TIL levels were also correlated with response, both in the pre-treated cohort and the untreated cohort, suggesting, again, that you need some sort of enrichment of pre-existing immunity to have response to checkpoint blockade in the advanced setting. So we come to the Impassion 130 phase 3 design. So this has recently been the basis of approval of atezo in the advanced TNBC setting. So this was a randomized trial looking at the addition of atezo or placebo to nab-paclitaxel. I'll just highlight some notable features about the inclusion criteria, that these patients had no prior therapy for advanced TNBC. They had to have had at least a 12-month disease-free interval between last day of adjuvant chemotherapy and first day of treatment. Liver metastases or the presence of was capped in this population, and PD-L1 status was not required to be positive, but the co-primary endpoint was in both the ITT and the PD-L1 positive population. So just to cut a long story short, the interim analysis in the ITT population for overall survival was not very positive. It showed a slight increase in median overall survival with a p-value of 0.08. But because this p-value was trending in the right direction, the statisticians were then allowed to look specifically at the PD-L1 population, and you can see this was 41% of the ITT population, and this was indeed where the signal seemed to be the strongest, showing an increase in median overall survival of around 10 months, but more impressively, a 2-year difference overall survival of around 16 or 17%, suggesting that these patients achieved a very durable response at 2 years. So again, highlighting the fact that these, specifically in the advanced TNBC population, there needed to be enrichment. So in this case, these patients were PD-L1 positive, derived most of the benefit. And again, there was a significant number of patients in this specific trial that had received no prior adjuvant chemo. And this is around 40% of the population. And you can see there that these patients, again, seem to derive the most benefit from the addition of atezolizumab. So what about HER2? So I'll just remind everyone here that trastuzumab actually requires NK and T cells for efficacy. And this is probably why TILs are important for a better prognosis in the setting of trastuzumab and chemotherapy. And this is probably the case for pertuzumab as well, though I've not seen that experiment being done. You can see here that this experiment looking at mice that lack NK cells show that trastuzumab is not as effective in these mice. And again, in mice that lack TMB cells, you can see again that trastuzumab is not as effective in these mice. So this gives us this model of trastuzumab efficacy, that trastuzumab binds the HER2 positive cell, it inhibits oncogenic signaling, it causes FCR-dependent ADCC, causing antigen presentation, and CD8-dependent anti-tumour immunity. And this generates anti-tumour memory. So this was the basis or the rationale of why we wanted to combine pembrolizumab with trastuzumab in advanced HER2-positive breast cancers. And this was the Panacea study, and that's recently been published. And this was a single-arm study looking at trastuzumab-resistant patients. Patients had to have had confirmed PD-L1 positive or negative status on a recent metastatic lesion, and they received trastuzumab and pembrolizumab until progression. So interestingly, in this study, if you're PD-L1 negative, you derive no benefit. However, if you are PD-L1 positive on a recent metastatic lesion, then there was some benefit observed with a confirmed objective response rate of 15% and a clinical benefit rate of 26%. Note, however, these patients were heavily pre-treated, and of course, at the time we designed this trial, we didn't realise how important prior treatment was. But just to highlight the fact of this concept of enrichment required for the advanced setting, that if you just have a little bit of T-cell infiltrate in your metastatic lesion, your response rate is markedly increased. So as little as 5% can give you a response rate of nearly 40% and disease control rate of 47%. They're highlighted in purple. But the very nice thing about this study was that we've started to see this hint of a plateau on the curve. And you can see here in this overall survival analysis that the patients that did respond are continuing to still be alive. And with further follow-up, I think we'll see this plateau increase. So the KATE-2 study was first randomised data in the HER2-positive setting, and this was looking at atezolizumab or placebo added to T-DM1 in patients with previously treated HER2-positive breast cancer. The primary endpoint was in the ITT population, and you can see that that endpoint here was negative. But you can see again, consistent with other studies in the PD-L1 positive population, that there was an increase in median PFS, so nearly 40% increase from 4.1 months to 8.5 months, and we await the overall survival data, which is pending this year. So what have we learnt so far with regards to immunotherapy, or specifically PD-L1 inhibition? That advanced breast cancer requires enrichment of pre-existing anti-tumour immunity. At least in advanced disease, the endpoint of choice is overall survival. Prior treatment seems to make a difference to response rates, and nab-paclitaxel and T-DM1 do not seem to be able to change a low TIL to high TIL patient, or PD-1 negative to positive. The immune context of advanced disease is very different to early stage breast cancer. I mean, this is probably very obvious from the fact you have metastases in different organs with their own different microenvironment contexts. And I think, however, given the genomic instability associated with many of these tumours, immunotherapy will be required to improve survival ultimately. So just lastly, I'm going to touch upon clinical data in ER-positive breast cancers. So meta-analysis by Dr. Denkard showed that despite ER-positive breast cancers having a paucity of tumour-infiltrating lymphocytes, higher levels of TIL are still correlated with higher rates of PCR. But the most interesting thing about this particular analysis is that the high TIL, despite being associated with improved survival in TNBC and HER2, is associated with worse outcomes in ER-positive breast cancers. So this suggests that the presence of TIL in ER-positive breast cancer is associated with adverse biology that we currently cannot impact. Despite this, the I-SPY data showed very impressive increases in PCR rates with the addition of pembrolizumab to high genomic risk ER-positive breast cancers, almost 3 times increase, which has led to subsequent phase 3 trials in this setting. So I'll just leave by saying that we actually know very little about how estrogen modulates immunity. There's some data, some very old data, looking at how estrogen signaling drives myeloid cells, how estrogen regulates both innate and adaptive signaling, but there are estrogen receptors on all immune cells. There are differences between males and females on how they react to infection, autoimmunity, and inflammatory disease. And of course, there are different changes in our immune systems through the menstrual cycle in females and, of course, pregnancy. So I suspect that blocking estrogen will be important for immune responses in breast cancer, and it may not be only T cells that are specifically important in estrogen receptor positive breast cancer, but there's a lot of work that needs to be done. So finally, in conclusion, there is strong rationale to target immune pathways in breast cancer, and the first steps have been taken with the approval of atezolizumab in advanced TNBC. There's strong evidence that the TIL biomarker significantly improves prognostic estimations of survival in patients with early-stage TNBC treated with adjuvant chemotherapy. So far, regarding PD-L1 or PD-1 blockade in the advanced population, it seems that we need to select these patients for pre-existing immunity. How we do that is probably going to rely on multiple different methods. We still don't know if we can convert TIL low to high. I suspect we'll need to go earlier stage, but perhaps focus on higher risk. But in contrast, a lower stage high TIL TNBC may provide opportunities for traditional cytotoxic chemo de-escalation. And for early stage disease, many questions remain. The best PD-L1 or PD-1 agent, which assay, the duration, what endpoint, the best chemo backbone, best HER2 targeted combinations, and best checkpoint combinations. So I thank you for your attention, and I'd like to acknowledge my lab and funding agencies. Thank you.
Thank you very much. Wonderful talk. I think it's a bit behind time, so thank you very much. Oh, right. Oh, okay. Sorry about that. One brief question, please.
Sure. Sherene, lovely discussion. For many years at this meeting, we heard about Ki-67 as a prognostic marker. It's a very powerful prognostic marker, but because of issues of standardization and threshold points, it never really has entered routine decision-making practice, at least not frequently in the States. How do we avoid that fate for TILs?
Sure. So Drs. Denkart and Salgado have been hard at work at this. We have a TIL working group, and we have published reproducibility publications where, using the data set on the TIL website, you can improve your quantification of TIL to be aligned with other pathologists. And we've actually published that your quantification does improve after this training exercise. And actually, at the high level of TIL, the reproducibility is actually very good. So if you're looking at 30% or above, the reproducibility is much higher.
Okay. Once again, thank you very much.